That was a fantastic panel. I learned a lot and was inspired by equal amount. I do have a question that comes out of the block, and this has to do with circling back to trust. Now, many of you indirectly kind of hit on this. What's your approach to getting trust and gaining trust, and how important is this trust issue in being able to move the needle? So I'll just open it up, and I'll have a couple people take a shot at that. I know that's a
This is
hard one.
Alma. I could start. Um, I mean, like I mentioned, it's the key. Trust is the key. And when you're working with the populations of people that are afflicted with the health disparities, and for me, it's the Crow Indian people, indigenous people, and so, like I said, there's just no other way I can best describe it, but our people have had their guard up because of mistrust that goes back to the historical trauma. And so it was very important to approach them in a manner where they felt that they could trust. And so in the way that it worked for us was utilizing that community-based history research. First of all, my people trust me in who I am and what I've been through. And so that was the reason why they had to, first of all, trust somebody that they know. I'm somebody from their community and I'm working with others, the researcher and the team coming in to begin to help our people. And so the way that it had to be done was we'll utilize our own people. It has to be someone they already know and they feel they can trust. And again, the mistrust of what we have available, the Indian Health Service. From the previous session, it was mentioned about, the iniquities of just, there's misdiagnoses, and that takes place at the Indian Health Service. We're talking about that structural racism. We're talking Indian Health Service is there to meet the needs of the Crow Indian people. That's what the government has given us. But there are many people that go in, and because of the racism, I'll just be blunt, there's not the real thoroughness or care from the medical provider to listen to this person. Is there really communication between the patient and the provider to where this is what's going on? This is the symptoms I'm experiencing. Do they really feel comfortable to trust this provider and tell them? And then so they're going in and nothing's done, and there's misdiagnosis, there's no diagnosis. And there's been many people that have been diagnosed at a later stage of cancer, not so much because of they're not going in for the early screening, that's there too, but there's been that misdiagnosis. They haven't been diagnosed until later. They had to go referred out from the Indian Health Service into Billings, finally, to get like a second opinion, and they were diagnosed. So that really kind of came out clear. So I wanted to share that. It just kind of hit me that first session.
I appreciate that. And it brings up my follow-up question, and then I'm going to turn it over to Gwen for her question, is what are our you hit on the point that they trust because they find you trustworthy. What are your institutions? And I would really like to, either from CMS or from an academic institution, UCVS, or from Deborah, what are your institutions doing to have institutional trustworthiness? It's one thing to build trust. It's another thing to become trustworthy. So what are the active things that your institutions are now doing to sort of look at your own and building your own and working on your own trustworthiness before we approach communities?
I'm happy to start that question, to start with that answer if possible. And I'll just start by thanking all of the presenters for the incredible information that was shared today. Certainly, I've learned a lot, and I'm looking forward to additional discussion. I will say from CMS's perspective, we are really focusing on increasing our stakeholder engagement. And for our agency, we're having listening sessions across the agency to hear from all of our stakeholders and taking that information back into our agency as we're thinking about our policies and programs. As a part of our strategic plan for the agency, advancing health equity is one of the pillars that our administrator is bringing the agency together around to understand how we can address these issues and that underlie our healthcare system. You know, for our office, that's critically important. We have been really focused on developing these relationships with our stakeholders, and so we identify partners across those populations that we focus on within our office to keep that door of open communication, to be responsive to the needs of our stakeholders. And just using the COVID pandemic example, early on, as we witnessed the level of vaccine hesitancy in many communities, we had to acknowledge, your first question was about mistrust. And the government, many people did not trust information coming from the government. But because of relationships, that long-standing relationships that our office has worked to cultivate over the years, we were able to hear those concerns from our stakeholders and work to develop informational resources that our community partners could share within their respective communities. So I would say that having that open communication builds trust, because communication builds relationship. And that is a part of how we can address some of these issues that have been discussed today. Thank you.
So if I can just jump in, Robert, I think it's a really great question. So at the Patient Advocate Foundation, we work with patients every day. And for us and for our patients, this is not, it's not an intellectual exercise. This is not an academic pursuit. This is very, very real. And oftentimes, hearing those words, social determinants, health disparities, you get the sense that these aren't real issues affecting real people. And I think when you talk about how do we really cultivate trust and make sure that we're meeting the needs of patients, one thing that we do is realize that patients need help right now. They can't wait for us to solve this problem. They can't wait for us to figure out structural racism and systemic racism and the health inequities. So we really work to help patients one at a time, while we're also working towards that larger challenge of fixing, if you will, the healthcare system. So I would just encourage everybody here to remember that while it feels on these panels sometimes like a very academic or intellectual conversation, there are people dying right now because they have to decide between medication and food. And we see thousands upon thousands of patients every year making these hard decisions. And so when you think about trust, bring solutions to the community, to the patients. That's something that we really, really try to do, is bring resources, bring solutions, and help patients with their day-to-day needs while you're also trying to solve these big problems.
Great. Thank you, Rebecca. And I think it's, the other thing I would like to point out is that it's tens of thousands of patients that we help. I mean, we say thousands because but if you really look at if you look at how many patients we serve, it's a huge amount, but it doesn't even begin to touch what is the need out there. So one of the things that we talked about when we started these conversations is we talked about justice, and I wanted to ask Deborah Joy to start off with that, and then maybe Alma, I have a more direct question for you about this, but how do we get this? How do we look at this in a framework of justice, not just and creating a just system?
Yeah, thank you for that. And thank you again for the opportunity. It's so important to really address and understand that you cannot get to justice and equity unless you acknowledge history and acknowledge the wrong that was done and the mistakes of the past, right? So we see this now with kind of a rampant effort to stop history being taught because it is a racist history. And so that only serves to further endure systems of oppression, right? So the way to advance justice is to really see all that you do through an equity lens, right? And so I'm going to talk about two related topics. One is this last topic of trust, right? And so there's three specific things that you need to do to build trust. One is transparency. And that has to do with the point I just made about history. Acknowledge what is, and talk about those things that have worked and not. That's transparency. The second is accountability. And that is be accountable for the things that you say you're going to do and do them. And when they don't work out, be honest about it, right? And then the third is creating psychological safety, which is that relationship such that I feel like I can bring my whole and authentic self into this relationship, in this conversation, and that I will not be judged based on any other identity or demographic I might represent, right? And so by doing that, you get to this point where you're on equal footing, right, with someone, and you're building a relationship together, and that's a relationship of trust. The other thing that I want to talk about, and I'm not sure if this is what you're referring to, Gwen, but I'm going to mention it because I said it, talked about it briefly in my conversation, and that is, you know, really our biggest challenge in advancing equity right now is the distraction, intentional distraction, to not want to talk about racism, to not want to talk about structural racism and institutional systemic racism. Let's talk about anything else but that, right? And that manifests in this use of this idea called whataboutism, right? So instead of, if there's a conversation about let's address and undo racism structurally and systemically in the institutions in which we work and in the practice of medicine, inevitably someone will say, well, what about disabilities? Or what about, you know, gender? Or what about poverty? As if those things don't exist in discussing and trying to undo racism. So let me start with some definitions. So whataboutism is a strategy, both in our professional and personal environments, that allow the subject to be changed and deflected into something else, so that we don't have to talk about what is the main concern and issue, and that is the issue of racism, right? And so, you know, just as an example, and the way to combat this is with data. So when someone says in a conversation, what about disabilities? And you're talking about racism, it's as if to say that disabilities don't exist in communities of color. And so let me just state the facts, and that is 24% of Native Americans have a disability. Over 20% of African Americans have a disability, and both those rates are higher than non-Hispanic whites in disability. So this notion, this whataboutism, kind of takes us away from that the true conversation, which is, and this is, I'm talking, this is real. When you address racism, you are fundamentally addressing every other oppression. You cannot fix racism and not kind of take care of all the other oppressions. They are interrelated, right? So this might be a kind of a roundabout way of answering your question, but the way to advance equity and social justice is to address and undo racism, period.
Great. No, that's perfect. And I wanted to ask Alma a question. It always catches me up when I think about what you talked about, as you referred to as land loss, but when in an earlier conversation you actually stated the millions and millions of acres that were taken from your people. I think it went from 200 million acres to I don't remember how much, but it is extraordinary. And I've heard other people talk about the erasure and of indigenous people in this country. And when I think about justice and I think about health equity and I think about the truth, I think that's one of the things that came out loud and clear in that other panel was that we have to state the truth. I just want to hear your thoughts and your ideas on that. I know you talked about forgiveness, but what do you think about when you think about justice and you think about equity?
So yeah, that's really, I mean, even this this whole thing, this whole concept of historical trauma, we had to bring it in this last research intervention. We had to ask people that I interviewed, 20 people who have a chronic illness, has historical trauma. Do you think that it's affected people, the Crow people, from ending up with chronic illness conditions and how they cope with it? The answer was yes. No question, no doubt at all. Yes, it has. And some people really opened up, and even one person said, don't get me started. And so I feel that that's the root. We mentioned about that root cause. Historical trauma and current trauma is the root. And we have to, as far as, receiving justice, I mean, will justice ever be done, for us? Will the millions of acres that was taken from the Crow people be returned? No. I feel that the only way is that we begin to just understand it. Our people need to understand, most of all, that what I'm going through today links back to what happened to my ancestors. And it's been passed down through the generations. I'm diabetic, and it goes back to what has happened. Our people are coping through substance abuse and use, alcoholism, the drugs, the pain medication to try to cope. But the best way for us to begin to just help our people overcome this, and I heard the word oppression. It's oppression. Oppression hangs heavy over the Crow people. And we feel like we're just in this bondage, literally. And we see it in it's manifested in our physical environment, in our poverty level, in our health conditions. But really, the root is it's spiritual. So we're going to use our spiritual value to help our people overcome. And the key is forgiveness. And it's not that we accept what was done to us, but we have to realize how powerful forgiveness is, and that it's going to set us free, and this oppression will lift. And individuals need to begin to walk the path of healing. It's going to be a journey, because it's been years that we have harbored in our hearts what's been done to us. And I know, I've been to some conferences, I'm telling you, put on by Indigenous people, and they can be very radical, speaking the truth, putting it out there, showing the facts. And yes, that's, we need to see that. It was devastating. But how are we going to overcome this? Continuing to talk about it, we can stay in that mode, and it will not do us any good. But until we help our people and guide them and to forgiveness, that's where we're going to see some freedom to let go, and that we can overcome this oppression that has just been hanging so heavy over our people for years. Our people need inner healing. I cannot speak that loud enough. That's the root cause. And so that's where we are headed, and as far as like justice, will justice ever really be done? But we can take it back We can use our own identity of who we are as Crow people. How did we overcome that land loss? How did we survive the smallpox epidemic that almost wiped out the whole Crow nation? Now we are rebuilding. Our population is growing. We're up to 14,000, and we were way more than that. We had a large population. That's why we acquired so much land. They were very dominant, a dominant tribe, reduced down because of smallpox. But we have to forgive. And I know I get very passionate, but I'll stop there. Thank you for this opportunity.
As a question to Laura, and maybe some others who want to chime in, we talk about social determinants of health and health disparities and these issues as if they're new. What Alma just actually pointed out, and what was pointed out and written about incredibly well in 1899 by a great social scientist of his time called W.E.B. Du Bois, was these issues. So what, Laura, gives us hope about either new knowledge or new approaches since 1899 about how we can either address and potentially, again, move the needle as it comes to using these social determinants of health, acknowledging that they're there, but using them, again, as additional information to close the gap?
Oh, such a good question, Dr. Nguyen. I mean, I think it goes back even further than 1899. The Virchow and Hippocrates and there's so many people who've pointed out that social and medical conditions are intertwined over time. At the same time, I do have some hope, and I do feel like in the last decade we've seen a bit of a sea change in the availability of tools and the interest in using those tools. And when I talk about tools, I mean not just clinical tools, but also the kind of levers that health systems have to be better partners and community collaborators than we've had in the past. So there are new strategies, and I appreciate Dr. McIver's point about the kind of CMS's relatively new commitment to being a strong community partner, which we, frankly haven't always seen at the federal government level. But we have new opportunities. CMS is now authorizing ways of using money that we just haven't had before. We have new technology that is enabling us to merge data across both health systems and non-health systems, and an interest in using it. But I think that, as we find those new tools and as we start to engage them, we can't lose sight of all the really important substance that all the other speakers have been pointing to, which is you can use these for good and you can use them for, for want of a better word, for evil. And being aware of the potential unintended consequences and the possibility that these levers could be used to exacerbate historical trauma, to incur new trauma, is real. So putting into place some guardrails and some safeties as we do it, some real examination of how health systems are using them and employing them on behalf of communities, in collaboration with communities, is really important.
Thank you. And Dr. King, I think you're on mute.
Oh, can you hear me okay?
I can now, yes.
Okay. So I will answer that by what gives me hope, in that I think in the previous panel, someone said that, a year ago, we wouldn't have been able to have a discussion on structural racism in the settings that we're having them in today. And for me, working at CMS within the Office of Minority Health, we talk to many different stakeholders across the healthcare system. And what I can say, what has given me hope, really is the level of awareness to the true importance of these issues, and people being willing and open to acknowledge where their system is on that continuum. There's some places and stakeholders that have done tremendous work that is serving as a model for where we are in this moment in time. But there are other systems that, they're saying, this is my first time having this conversation within our institution. What resources do you have to help us think through this? Because as we're having these discussions, we're confronting different levels of racism, from the institutional level to the interpersonal, the interpersonal level, at the individual level. And so it's a difficult time, but people are coming to the table and they're really trying to solve issues within their institutions. And I know I have not seen that in the 20 years that I've been working in this space. And so it gives me hope that something has transpired. Unfortunately, I think the pandemic had a significant impact on our culture, our society, with the social unrest that we witnessed and we continue to see, over time, that there is something about this specific moment. And so we have a presidential mandate as a federal agency to work on addressing equity in all of our federal programs and services. So for the first time, you have the federal government working on an issue that we, have not worked across the entire agency, all of the departments, in my known history. And so it's an exciting time of exploration, of looking to those who have paved the way. But I'm very hopeful because there's something that's just very different about the types of conversations, the willingness of people to be transparent and to learn. There is a moment of learning that's happening. And so we all, I think, can play a role in helping to shape what comes next. Thank you.
And LaShawn, I think one of the things that, there are so many things that you said that were important in that, but the opportunity to learn and the continuous learning that feeds change is really, that's, I think that's a difference in this critical moment. As was pointed out before, people would make statements and they'd say that they would promote equity. And Reggie Tucker-Seeley talked about that in his closing comments. But it was incrementalism and it was a little performative. There was not the action that was taken. And I think that's such a critical point, this learning, this integrating, and this really listening to each other in a very open way, with really open mind and open heart, in a kind of almost Buddhist way of approaching other people is critical if we're going to make any kind of, if we're going to make the change and do a different thing that we want to do.
Yeah. Can I just add to that, Gwen? Because I think this is, in fact, a unique moment, right? A lot of people who previously were shy about saying race equity or talking about racism are talking about it. The challenge, I will admit, though, is that very few institutions know how to operationalize equity. They just know how to write the good statement. They have great communication staff, right? So what does operationalizing equity look like, right? And I will say that's challenge number one. Challenge number two is that this is not an unlimited time or window. My prediction, I've had this conversation privately with Gunn, I think we have 5 years. We have 5 years if we want to really make fundamental change in this country in the direction toward equity. And I think what we're seeing in terms of the backlash against critical race theory is an acknowledgement that this is a window that for a lot of people, their desire is to shut this window, right? But operationalizing equity means that you have to change the structures that resulted in the inequities, and that is everything from the leadership of an organization, the governance of the organization, the funding. Does the funding and the budget reflect the statement that organizations have put forth? If they are saying that they are stand against racism, show me your budget where it says that you put money aside to invest in undoing racism, right? So that's, I think, where a lot of people get stuck, is in the operationalization of equity. What does it look like in your structures and policies, in your governance, in your accountability and metrics, in your budget, in human resources, in your leadership? So it is an extraordinary moment. I am so excited to be doing kind of diversity, equity, inclusion work at this time. But what I hear from the people on the ground is, show me the receipts.
Dr. Perez, I just want to piggyback on all of those important comments, because I'm struck by the disconnect between how much work has to be done and our 5-year window. Because I have that deep fear that we have the attention for 5 years, but the sort of very fundamental structural change that is required to enact, not just within healthcare systems, right, but also to really shift social investments away from healthcare and towards communities is so fundamental that it's going to take much more than 5 years. And I'm sitting with that dynamic, and I'm wondering from all of my colleagues on this panel what we do about the attention span. For those very fundamental shifts.
You just said something that actually I learned from one of my mentors, who said, you can tell a person what they really value, not by what they say they value, but by the time they spend on it.
That's right. That's right.
So
show me your budget. You show me your values. I think Reggie put that in the chat.
That's right. That's right. So I think that's a very important question. So I do have one quick takeaway. I know we only have a couple minutes, so I'm going to go fast. This will be lightning round. You have one action item that you're going to take away from here. So one action item that you think would actually have an impact in a positive way on equity in the context of policy. What one policy change would you have in mind, or what action item? I'm going to start with Dr. Joy Perez.
I would put money in the budget that says eliminating disparities and advancing equity. And I would make that 1/3 of the budget.
I like that. I like Sister Ngo.
I kind of already said mine. I think that while we're working on this change, we need to invest in direct services that are going to improve the lives, address social need and social risk right now, while we're trying to work on the bigger problem. So that's where I'd put a bulk of investment, so people don't have to wait.
Dr. McGeever?
So the policy change that I would like to see is for federal agencies to actually build the infrastructure for equity within the different departments across the agency. I know at CMS, we're focused on creating an infrastructure that will hopefully transcend time. So that's what we're working towards from a policy perspective.
I love this. Y'all ain't playing today. I love this. Dr. Gottlieb?
I think, my comments build on the others, but I think it's really about accountability. And I think you do that with budgets, you do that with performance measures, or the other infrastructure that Dr. McIver is referring to. I think there has to be accountability for health equity. And without that, you don't see those big shifts in the ways organizations operate.
Hey, going, you have the last word. It's only 30 seconds, but you got the floor.
Okay, is that me?
That's
okay.
you.
So they have to work with community people just like me. Go to where the people are at. If you want to build trust, it comes from your heart. Listen with your heart, and building trust takes time, and utilize people from those communities to work with the people there. That's the only way. You have to let people know that they are cared for.
Appreciate you all. This was a wonderful panel, and I am so glad we went the lightning round about the one action. And again, I love being a co-moderator with Gwen. It's one of my favorite things that I get to do. So Gwen, I'll turn the floor back to you.
Well, thank you all so much. This has been such a thrilling and exciting panel. And I've gone from being almost in tears to writing down furious notes about what I need to do next. And I think when we looked at, Reggie Tucker Seeley did a quote when we started this workshop, when we did our introductions. It's a quote from Jeffrey Vickers: "The landmarks of political, economic, and social history are the moments when some condition passed from the category of the given into the category of the intolerable." And I think that's what we really addressed in this panel. We looked at what and what we talked about in terms of our opportunity right now, which is that we have moved inequity, we've moved social justice or lack of justice into the category of the intolerable. So I want to thank everybody. This has been a fantastic panel, and I love also how everything, these themes just keep on building, and that we've all really taken to heart the challenge to be bold, to be direct, and sometimes to say uncomfortable things. So thank you. We are so grateful. And as always, I am so grateful to co-moderate with Rob Wynn. So we're going to go to a break, a 10-minute break. So we transition and come back at 1:55. It's actually, thank you.